Our next speaker is Dr. Bojana Budisin, who is a clinical neuropsychologist and researcher. She completed her PhD in clinical neuropsychology at the University of Windsor in October of 2013, and her dissertation focused on multifactorial presentation of impulsivity and utilization of various statistical modeling techniques when assessing impulsive presentation across developmental stages. And her talk is going to have nothing to do with that, in fact. She has very extensive clinical experience with across the lifespan in Canada and the US. She completed her postdoctoral training in 2017 at the Toronto Rehabilitation Institute with us, in fact, under my supervision. Among several research projects that she was involved in, she focused in particular on assessing the effects of cognitive behavior therapy delivered remotely to address mood disturbance in people with persisting symptoms of concussion. And I should also add that while she was in the middle of her maternity leave, we invited her to give this talk today, and she graciously accepted. And she is still in the middle of her maternity leave.
Thanks, Robin. Hi, everyone. So I will talk today about cognitive behavior therapy and persisting symptoms of concussion. So as we have just heard from Dr. Silverberg, after concussion, there is a host of psychiatric presentations that we should consider when treating this population, and depression and anxiety are commonly present. And consequences of these issues typically include reduction in quality of life, as well as reduction in ability to engage in daily activities, as well as work. Because at this time, the etiologies, so underpinnings of these persisting symptoms are still unsure, likely multifactorial, we need treatment that works irrespective of these underpinnings, and because people continue to suffer and need treatment. So we need to find something that will not be affected by what's going on underneath the symptoms, but likely be helping with the symptoms. And as we have just been hearing, CBT tends to show effectiveness in this domain. It has strong efficacy track record in research for populations with traumatic brain injury, as well as other neurological populations. It's not physically invasive, it's structured and time limited. Also, what is CBT? So this is a goal-oriented approach to therapy that lets us explore connections between our thoughts and behaviors and emotions with an aim to alter some of those patterns, cognitive as well as behavioral, which in turn will help with reduction of emotional disturbance. While CBT and treatment of that sort is highly needed by this population, people tend to meet barriers, access barriers, and perhaps due to not being able to take time off work or school or caregiving, they might not be able to access this type of treatment. Delivery of this treatment remotely, so for example via telephone, has been receiving a lot of attention, and is thought to be able to reduce these access barriers. For example, 90% of the people nowadays use telephone, so perhaps we should make use of that when trying to provide treatment. Also, the reason why we wanted to take a look at telephone-based intervention is particularly CBT, is because there is research coming out showing that showing successful remote delivery of psychological interventions, not CBT in nature, for subacute mild traumatic brain injury. Our group also has demonstrated successful treatment, so maintenance of the results in addition to feasibility as well as effectiveness of CBT delivered to those with more severe presentations, so moderate to severe brain injury. But the gap in research right now remains lack of randomized controlled trials for remotely delivered CBT for mood disturbance in persisting symptoms of concussion. So The study I will be talking about right now, that I'm talking about right now, is actually doing just that. We are aiming to address use of CBT in those with persisting symptoms of concussion and ongoing mood disturbance. So our aim is to assess the efficacy of CBT in a randomized controlled trial with an active education control group, and to assess the feasibility of remote delivery of CBT. I also want to mention that at this point in time, we are also collecting data that will allow us to examine the utility of booster sessions in different formats for maintenance of therapeutic benefits. So even though I won't be presenting on this piece today, it's important just to let you know that this is what we are doing because it has guided our randomization schedule. So when I talk about participants, you will notice that we have 3 times more people in treatment group as compared to the education group. In the interest of time, I won't go through each one of these points, but we had inclusion criteria as well as exclusion criteria. And if you look down to the exclusion criteria, the first 3 points are quite important because based on those exclusion criteria, many of our participants were deemed ineligible for the study, and this is something that dropped our recruitment rate. Primary outcomes included measures of anxiety and depression, including the DAS, Depression Anxiety Symptom Scale. The 3 subscales we looked at right now: depression, anxiety, and stress. We also use Beck inventories to track symptoms of depression and anxiety, the BDI and BAI, and the SCAT. At this point in time, we have preliminary data. I want to highlight that. This is how the sample is looking right now as the data collection is ongoing. So you can see that our CBT and education controls are pretty well matched. And also something that's important to highlight is that they're well beyond the acute stages of recovery. So at least 4 months or more, and some of them a couple of years after their concussion. So let's talk about our very preliminary findings at this time. So in terms of preliminary feasibility, we had at this point in time 196 self or therapist referrals. And using those inclusion and exclusion criteria that I presented, 25 were eligible for randomization. So either they went into the treatment group or the education group. And this was done after a brief phone screen and more thorough face-to-face screen. Out of those 25, 19 were randomized to CBT treatment. We lost only 1 person to attrition, who actually dropped out after 4 sessions, showing strong reduction in scores. But as you can see, a great majority completed all 8 sessions. So 14 completed all 8 sessions, 3 completed 7 out of 8 sessions, and 1 completed 6 out of 8 sessions. Of 6 randomized to the education group, we lost, at this point in time, none to attrition, and 4 completed all sessions, 1 missed 1 session, and 1 missed 2 sessions. Regarding preliminary efficacy, we tracked, as I earlier mentioned, symptoms of depression and anxiety, as well as overall stress, using the DAS. So if you look at the first and the third group of bar graphs, you will see significant decrease in symptoms of depression reported by the participants following intervention, following the CBT intervention delivered over the phone. It's the same pattern for overall stress. And in terms of anxiety, although there was at this time a decrease in overall anxiety levels as reported by our participants, it is a trend. We also wanted to take a look at just how they're doing from a symptomological perspective from session to session. So we tracked, at the beginning of each session, they received a questionnaire that they filled out, and they just told us basically how they're doing. And in terms of symptoms of depression, you can see a nice reduction in their symptoms overall. And it's, in terms of overall stress, a very similar pattern. So with this telephone-based intervention, they're reporting less overall stress. We also tracked symptoms of depression and anxiety pre and post delivery of CBT intervention over the phone using Beck inventories. The two green are tracking anxiety pre and post, and the blue and yellow are tracking depression symptoms pre and post intervention. And while we had a trend on the DAS when looking at symptoms of anxiety, here we had a significant reduction in symptoms of anxiety, as well as significant reduction in reported symptoms of depression. I also want to once again highlight these are very preliminary findings. We had an education control group consisting of only 6 participants, but what is encouraging is that we are overall not seeing significant changes pre and post delivery of education at this time. So what do these preliminary findings tell us? At this point in time, recruitment is in line with other RCTs, randomized controlled trials. However, even though it's low recruitment, once the participants were deemed eligible and engaged, they were very highly likely to complete the treatment and also engage in the session. So we had a good retention and we had a good session completion. So the preliminary feasibility in that sense is quite positive. Some clinical observations that we wanted to share with you. In terms of common concerns, our participants were mostly reporting reduced level of functioning in work and social life. They were also concerned with lack of control over their recovery and feeling misunderstood. So having their symptoms and struggles underestimated. Some frequent characteristics that we have observed anecdotally include black and white thinking regarding the injury and the recovery, as well as the confirmation bias. So notable attribution of everyday difficulties to the concussion, as well as the good old day bias that we heard Dr. Silverberg describe. There was also a focus on organic cause of these persisting symptoms. Finally, of importance, regarding the telehealth modality, so having CBT delivered via telephone, we didn't hear any complaints. We had several participants also tell us that they kind of preferred this modality over a face-to-face treatment, stating that it's more convenient and it's unintimidating. So overall, regarding preliminary efficacy, CBT, according to these preliminary findings, shows significant treatment effects for mood, anxiety, and overall stress. Given, once again, these are preliminary findings, we cannot at this point in time rule out any alternative interpretations of the findings. So, that being said, is it contact alone that is conferring all the mood benefits? Possible, but the fact that we are not seeing any changes on our measures at a significant level in the education control group, this is promising that CBT has something to offer above and beyond contact. Also, we were wondering, is it treatment effects or is it spontaneous recovery at that point in time? Perhaps spontaneous recovery, but we want to point out 2 things. First of all of our participants were outside of early spontaneous recovery window, which makes this point much less likely. And also, when we look at their SCAT scores, which measure the severity of symptoms of concussion, there was an improvement pre and post delivery of CBT, but most of the improvement was on the emotion items as compared to the non-emotion items. Given that the CBT intervention we implemented targeted specifically mood disturbance, perhaps it is that the skills they're learning that are helping alleviate their mood disturbance, which in turn helps alleviate their non-mood symptoms of concussion. And this improvement in itself can also then cause improvement in the mood. So it's a little bit of a chicken and the egg. As we continue to collect the data and increase our sample size, we hope to be able to answer these questions much more concretely. So thus far, our conclusions are based on preliminary findings, which show the CBT is a promising intervention for mood disturbance in people with persisting symptoms of concussion, and remote delivery is showing to be effective. The findings are also encouraging regarding feasibility. As I earlier said, once participants were deemed eligible, they were engaged, they were compliant, motivated to complete the treatment, which is very positive in terms of delivering CBT over a telephone. And once the study is complete, we will also have findings on maintenance effects that we hope to report on next year. And at this time, we leave you on this very cautiously positive note. And we wanted to thank everyone who participated in this study and put their time into this, as well as our collaborators. Thank you.
Thanks, Dr. Budisin. Any questions? We have time for a couple.
It seemed that when you were showing the characteristics of each group, that in the cognitive behavior group, they had suffered for a shorter period of time. And there seemed to be at least a clinically significant difference in the time that they experienced symptoms. And I wondered, was it statistically significant? And it was one of your early slides.
Yeah.
Do you know which one I'm talking about?
Yeah, the characterization.
So it seemed that there was a prolonged time of symptoms, or a prolonged time between the event and their treatment initiation. And I just wondered, could that not have an effect?
Possible. So you're saying that perhaps because they've been without treatment for a longer period of time, that may have some effect
They
on
may
the
be
results?
their ideation may be more fixed, that they didn't have the opportunity for earlier intervention. Yeah.
It's possible, and we'll consider that moving forward also in our findings. Most of the participants were quite far out at that point in time without treatment, so the chances are that there is stress building on, and that the ideas are being more fixed. So if with more time, we likely have to implement even more CBT.
Okay, thanks.
I noticed that your group had high average premorbid IQ abilities. Do you have any recommendations for working with average or low average verbal abilities?
Average and low average verbal abilities.
Yeah, so you had a very verbal group.
Yes.
Do you want me to take to the chairman's prerogative and
yeah.
respond? Well, so the protocol that Dr. Budisin has discussed was specifically adapted to this population, and often one makes clinical adaptations to the traditional manual, the Mind Over Mood manual. So we also administered this to patients with moderate to severe brain injuries in the chronic stages, many years post-injury, but with quite severe deficits, including verbal deficits, and found really robust benefits. So I wouldn't be discouraged, and I think that your clinicians would be able to make their own individual adaptations. But I don't think there would be less likelihood of success.
That's great.
Just wondering, the follow-up that you plan to do, were participants given any particular instruction regarding ongoing CBT that they would do on their own, or they have no instruction to continue with that and then you follow up later to make sure that works?
So that's a good question. So the follow-up actually comprises of 3 groups, and one group doesn't receive any follow-up, and then the other 2 groups receive some follow-up in 2 different modalities. And the participants are fully aware of that from the get-go. Also, we do provide our participants with the Mind Over Mood book, which they get to take home afterwards, which they now had. First of all, they had the ability to go through that book with a clinician specializing in this kind of treatment, and now they can go through it on their own. In terms of any other interventions, we always recommend based on a case-by-case basis if that's something they can benefit from in the moment. But it is, at the end of the day, their prerogative if they want to continue.
you have a question? Oh, one last question.
Sorry. Just in follow-up, are you going to look at the, the clinical significance? I mean, we want people to do all these interventions, but basically we want them to get back to their lives.
Right.
And so, I don't know if you have data on that or if you're planning on collecting that data to see how many work to schools.
Yeah, we do have data, actually. That's a great question because we, at the end of the day, do want them to be living the lives they can enjoy. So we do have also questionnaires and data that we're collecting, like quality of life questionnaire, actually called that way, that we can hopefully examine that moving forward.
Thank you. Thank you very much.